Good morning, everyone, and welcome back to the second day of Epilepsy Awareness Day. I hope everyone is learning a lot and enjoying all the speakers and the booths, the virtual booths. We're starting off the VA Epilepsy Centers of Excellence program with this first talk presented by Dr. James Chen, and he will be speaking on post-traumatic epilepsy and treatment. Thank you. Go ahead, Dr. Chen.
Okay, thank you, Natalia. So the topic I would like to focus on today is post-traumatic epilepsy. And this is one of the oldest type of epilepsies that's known to human beings. That's from the ancient times. People have associated head injury with the development of seizures and epilepsy since probably as far back as human history. Here I would like to share with you a very interesting patient, Mr. Gage. Mr. Gage is probably the most notorious patient in neurology, at least in contribution to the development of understanding the human brain. He really has made quite a bit of, because of the accident he suffered from, he really has contributed greatly to the understanding. So what happened is he was a foreman for the railroad construction, and in 1848 in Vermont, and there was an accident of an explosion, and a big metal piece rolled just went through his head from his chin area on the left side and went out from the top of his head. And so this is really a severe injury, and you can see that after the injury he fully recovered, and he held the big metal rod in his hand. So that's a rod that went through his head. And even with such a severe head injury, he walked away from the accident. He was not paralyzed. He actually stood up and walked away from that accident. So that led us to the understanding of a part of the brain called orbitofrontal. It's a part of the brain that right above the eye socket. That area is called orbitofrontal lobe. And that's the area related to human personality. And Mr. Gage actually has a significant change of his personality. He was a pretty decent church-going family man, but after that injury, he would use foul language all the time and having completely disinhibited behavior. And because of that, he joined the circus and joined the shows and make a living out of that. But also, unfortunately, he also developed post-traumatic epilepsy. And he actually come to his demise about 5 years later because of that. He got into a condition called status epilepticus. Basically, it's a non-stop seizures. And so there were several take-home message for people here is head injury. Even people recover from the head injury. The damage could continue to spiral down if the subject develop post-traumatic epilepsies. And even with post-traumatic epilepsy is now treated and controlled, it could continue to spiral down, including paying the ultimate price of losing his life, like such from status epilepticus. 1850s was a time that before we have any pharmacological treatment for seizures and epilepsy. The first treatment was in 1850s and 60s. Bromide was introduced in London. So this is one of the era that we can really observe how things after an accident or head injury, how the post-traumatic epilepsy will gradually evolve over time. And basically what happened to Mr. Gage is he suffered a major head injury. Luckily, he walked away alive and then was not even hospitalized for that severe injury, but he developed post-traumatic epilepsy. And 5 years later, he succumbed to that injury, the consequence of that injury, which is post-traumatic epilepsy. and status epilepticus. So what I would like to do today is to share with you a little bit better understanding of what is post-traumatic epilepsy. And it's a type of epilepsy that usually develop within 2 years of head injury for most of them. But some of them actually could develop a little bit later, not right away. It could be, especially with severe head injury, like a person with a bullet wound to the head. It could develop many years later, and it's still considered a post-traumatic epilepsy. And then when the head injury is more severe, the likelihood of developing post-traumatic epilepsy is higher. So the definition is patient have 2 unprovoked seizures after a head injury. And the unprovoked means it's not from a provocation such as intoxication or using drugs or whatever reasons. It's spontaneous seizures, 2 or most spontaneous seizures after a head injury. And that seizure cannot occur within the first 7 days. In the acute phase of a head injury, usually defined from a week, some people use 1 month. The seizures are usually provoked, and I will show you why that's considered provoked. If you look at this histogram, you can see that after head injury, if patient develop seizures after the head injury, and from patient who never had a seizure before, most of the seizure occur in the first week, and then there was some sporadic distribution after week 2. So there's a clear distinction that the seizures that develop after within 1 week of a head injury are considered provoked seizures. That's from the acute head injury and causing a seizure. And those seizures might not continue as a spontaneous seizure, which we'll call epilepsy. It's a spontaneous recurrent seizures. And some of these patients might have acute head injury and then develop provoked seizures within a week of the head injury, but it never come back. It just, stop after that. So only have provoked seizures. So there's a conceptual understanding that I would like to discuss is there were 2 different concepts. One is provoked seizures. One is post-traumatic epilepsy. And the post-traumatic epilepsy are those patients, after head injury, and usually they went through a silent period. It could be up to 2 years or longer, and then the seizure started, and it's a spontaneous seizure, spontaneous recurrent seizures. So those are the real post-traumatic epilepsy, and that will be the focus of today's talk, because this patient might suffer from a trajectory, actually a spiraling down trajectory. Just like what I mentioned about Mr. Gage. And the risk of developing post-traumatic epilepsy is related to the severity of the head injury. Clinically, we can classify the head injury into 3 different clinical categories. One is called mild TBI, traumatic brain injury. The other one is moderate. And the third category is called severe. And it's based on clinical definition. It's not based on MRI, CT scan, imaging, or others. It's just based on the clinical presentation. So the mild TBI are typically, they could have an alternation of consciousness or loss of consciousness. The traditional term of describing this condition is like a concussion. Like anyone who has a concussion, they count it having a mild TBI. And the alternation of consciousness and loss of consciousness altogether should not last longer than 30 minutes, and they should not have any scar fracture. So, and then if you do MRI on this patient, basically everything looks normal on the MRI, and so this are clinically considered mild TBI. But again, I emphasize we don't go by the MRI for doing the classification, but this is a specific group of patients. They have a mild TBI, but there's a tremendous implication even with a concussion. because it does increase the risk of developing spontaneous seizures, which is post-traumatic epilepsy, afterwards. And, the second category is on moderate TBI, and it's very similar to the first category, but the time their consciousness alters is longer, like from 30 minutes to 24 hours. Most of them could be just for a couple of hours, just longer than 30 minutes, and they recovered. They might recover with a headache, just like my TBI patient. They might recover. They don't have alternation of consciousness anymore. They don't feel confused, anything like that. But it's within 24 hours, those alternation of consciousness disappear. And they might have a skull fracture, but there's nothing really involving the brain. It's just a bone could crack a little bit or something like that. And so they are considered moderate TBI. The severe TBI is different. The severe TBI is they really have pathology in the brain, like brain contusion, the intracranial hemorrhage, or if they are in coma for more than 24 hours. So these are three discrete, distinct groups of a patient who has TBI. And sometimes you can lump the mild TBI and moderate TBI together versus the severe TBI. And I can show you why. The risk of developing seizures, the 5 years cumulative probability is quite different between the mild versus the severe TBI. The mild TBI only 0.7% chance versus moderate TBI is 1.2%, and the severe TBI is 10%, which is significantly higher. And so those people who suffer like a bullet wound to the head or something, those are severe TBI, they really have much higher chance. And this is based on one study. If you look across different studies, the number is a little bit different. And you can see this is summarize some of the larger scales of study and the percentage of patients who develop late seizure actually post-traumatic epilepsies. So it could be as high as 17%, and even over 5 years, the cumulative risk could be from 10 to 13%. But if we just look at the mild or moderate TBI, it's really, the curve doesn't go up. The slope is very flattened. It's at 1.2% or 0.7%. And this is another epidemiological study looking at the relative risk or how soon they develop post-traumatic epilepsy after a head injury. And there was 3 different color-coded line. The deep blue line is mild brain injury, and you can see that the curve quickly slide down here, and like about 2 years, this almost back to the flattened lines. The severe head injury, in contrast to severe head injury, like within the first 2 years, the risk is pretty high. But even 10 years out, it still hovers above the background. The background, the baseline is this dashed line. So it's really hover like around 4% compared to the okay. So this will show you that most of the risk is within the first 2 years after head injury, but up to 5 years is when that we will consider reliably that the patient had head injury within 5 years develop a seizure, and there's no other reason for the seizures to occur, the spontaneous to occur. We still will count it as post-traumatic epilepsy. It's based on this understanding. And there were several high risk factors, and there are actually more factors that are associated with the development of post-traumatic epilepsy. But if they have a skull fracture, not a simple skull fracture, is a depressed skull fracture, means the bones sunken in to the brain tissues. Or the contusion in the brain, intracranial hemorrhage, or a long time coma, the coma scale means how deep the coma is pretty low score. All those are considered high risk factors. So this would also go through a different type of numbers, like, for example, based on the Korean War study and the Vietnam War veteran studies, about half of the veterans who had a penetrating brain injuries in the war zone, from the battlefields, about half of them would develop post-traumatic epilepsy. And this number is quite interesting. It depends on which side of the coin you look at it. It's very, very significant. A very bad head injury, there's a 50% chance they will develop post-traumatic epilepsy. But you can also ask the question, how come the other half of the subject they not develop epilepsy, after such a horrible head injury? So that would be one of the reasons we want to study what is the mechanism for the development of post-traumatic epilepsy. And I will come back to that later. And then just based on the statistics that I showed you earlier, so about 50% of patients, the first seizure occur within 1 year of a head injury, but still about 15% of post-traumatic epilepsy could develop more than 5 years later. And even from the Vietnam head injury study, 35 years after a head injury, just like I show you, the risk never returned to the control baseline. 35 years later, they still could develop post-traumatic epilepsy, which is very interesting how this would develop. And this is another study from 1960s. It's a very, very simple study, just hundreds of subjects, and they just mark the dot. Each dot means a seizure. So like after head injury, the 0 time is a head injury. This is the years after. Sorry, they will track it for 11 years. And how long after the head injury they develop post-traumatic epilepsies. And you can see that within 1 year, we can get probably around 2/3 of the patient, like all the patient above the 2/3 patient already develop post-traumatic epilepsy. By 2 years after head injury, it might be around 80% of patients. But even we go up to 5 years, they will still, this group of patients, that 15% of patients, they still haven't developed post-traumatic epilepsy. But if we go out to 8 years, that probably will reach over 90%, 90-some percentage of patients will have developed post-traumatic epilepsy. A very simple study, but that layout will lead you to understand how thin it will evolve over time. If you see a straight line, means the seizures are too frequent to count, not a discrete seizure anymore. And so the question is, since there's a time gap from the onset of head injury to the development of a post-traumatic epilepsy, and so people think that, yeah, probably I should give this group of patients seizure medications, and hopefully that will stop the post-traumatic epilepsy from coming out, from development. Unfortunately, there were many randomized clinical trials that were done over the years in the past several decades. The sad conclusion is there was no beneficial effect. There were a few reasons for that. Most of the studies actually were conducted using the older type of seizure medications like phenytoin, phenobarbital, carbamazepine, valproic acid, and all this older medication, because this study it was in the like from 60s, 70s, 80s, and 90s. So at that time there were not too many choices of different seizure medications. So the conclusion was made based on the study from all the seizure medications. I don't know whether we can extrapolate this to the newer seizure medications, but most likely we can. The reason is the seizure medication we use are screened and selected first in animals and then in human clinical trials, but they were selected based on the markers of a stopping seizures. So they are anti-seizure medication. They are not selected based on their mechanism to stop the development of seizures. Means it's anti-epileptic. It's not anti-epileptic, it's anti-seizures. So since all this medication are anti-seizure, means they can stop a seizure. The patient have an acute seizure, you give them this anti-seizure medication, the seizure stop. But the seizure stop is like it's a little bit different process from the development of epilepsy. We use a term called epileptogenesis. And the epileptogenesis is a transformation of the brain structure in terms of structures and physiology and functions and to sustain a spontaneous recurrent seizures. And that process is called epileptogenesis. And all this medication doesn't seem to have any beneficial effect on stopping the process called the epileptogenesis. And there was a huge meta-analysis and just pull the 10 biggest randomized controlled clinical trials for a total of 2,000 patients. This was done in 1998. And just the same conclusion from this large scale of meta-analysis that the seizure medication is only effective in reducing the risk of early provoked seizures. This means a seizure within 1 week of head injury. Yeah. So the patient who had an acute severe head injury, they should be put on seizure medication, but probably only for a week, only in the acute phase to prevent the provoked seizure from coming out. However, there's no indication to keep the patient staying on seizure medications because there's no beneficial effect. It doesn't prevent the development of post-traumatic epilepsy. And also on the other hand, if you do insist on putting head injury patient on long-term seizure medications, they actually tend to suffer from a higher incidence of the side effects. But there were a few academic points on the clinical trials. And so I would like to point it out that, you know, even the conclusion is like that. There definitely were a few important things that were controlled to reach the conclusion. One is the heterogeneity of patient population. So we have the treated group and the control group who are not treated or treated with placebo. And however, it's very difficult to match the severity and location of TBI between the placebo group and the treatment groups. So it might not be a fair comparison, even if it doesn't show any benefit. And that doesn't really rule out a subgroup type of a patient might benefit from a long-term prophylactic seizure medication treatment to prevent the development of epilepsy. What I'm saying here is the lack of evidence doesn't equal a negative evidence. What we can say is we have no evidence to support the usage of a seizure medication after head injury. But that doesn't say that because the study design, we cannot say it's a piece of negative evidence. It's just we don't have the evidence. We also know that the development of epilepsy is brain region dependent. It really depends on where the brain suffers a head injury. If the head injury is in the area of brain called cerebellum, that's very unlikely to have post-traumatic epilepsy. But if the brain injury is in the medial temporal lobe area called hippocampus, there's a better chance that a post-traumatic epilepsy would occur, and that will really become the seizure focus. And all these things are not fully controlled in the clinical trials. And the other thing that's not fully controlled is the timing of the AED treatment. And there were a few lines of evidence showing that the timing of treatment might be crucial. And one is uncontrolled study was conducted in 1979. Epidemic was done in Vietnam. Patient with head injury severe head injury was quickly given 1 gram of phenytoin, which is seizure medication, right away. And then seems that there's a significant difference between the risk of PTE, post-traumatic epilepsy. 10% occur with TPE in the treated group versus 50% in the untreated group. So, but it's a small scale study, it's not controlled. So the quick treatment might have altered something, suggesting that if you really want to change the final outcome, you might have to act right away, and the intervention should be done right away. And all the clinical trial, large scale randomized clinical trials, those are not patients treated right away. Those are patients treated with some time gap. And if this is really a critical factor, then all the studies will not designed correctly to find the answer. And so that could be one issue. And then that is not only in the clinical study, also in animal studies. There's a model called undercut head models, an animal model of post-traumatic epilepsy, and it actually show a critical period 3 days after head injury. That vaporic acid could change the development, the probability of developing epilepsy over time. That means early treatment might be important. Okay. So, however, on the clinical side, based on the evidence we have, we basically just have to say AED, anti-seizure medication, was only good for treating the early provoked seizure within 1 week of a head injury. The head injury, you might keep the patient on seizure medication up to a month, but there's really no indication to keep them on a longer treatment. The seizure medication actually might inhibit the recovery of the brain functions after head injury, but the brain would take might be a few months up to 2 years for recovery and reconnections, and using seizure medications might actually interfere with this normal recovery process. It's doing something bad to the brain, and this is more of a conceptual with limited evidence, but it's a real concern. So on the clinical side, we would not recommend to keep patient on seizure medication long term, after head injury, because there's really no benefit, and with potential side effects, and might hinder the recovery from a head injury. So epileptogenesis is this process that epilepsy develop after epilepsy develop, and then for post-traumatic epilepsy, this after head injury. There were many molecular, cellular, or network level changes in the brain that would make the whole brain more excitable, and because of the higher excitability over time, spontaneous seizure will come out. And the brain tend to have two opposing system. One is on the excitatory side, one is on the inhibitory side. And it's used different chemicals. Like, for example, the glutamate receptors, one of the glutamate receptors is called NMDA receptors. It's on the excitation side. The GABA, GABA is a chemical that actually binds to a GABA receptor, is on the inhibitory side. And all the physiological function of the brain is really a balance of the excitatory system and inhibitory system. And during the process of epileptogenesis, the balance of the two systems actually was off, and that has become much more excitable. The whole system become much more excitable, and because of that, spontaneous seizure could happen. So when is the onset of this epileptogenesis? That would be the question we should ask if we really one day want to find a reliable intervention to prevent the development of post-traumatic epilepsy. So if we could determine the onset time, we would know when to start the anti-epileptogenic therapy, and to stop the process or to reverse the process. However, at this point, it's a no. We don't know when it happens. And then related to this question is if there's a genetic predisposition. And remember the Vietnam and Korean head injury study showing that about 50% of patients with bullet wound or missile type of penetrating wound to the brain would develop post-traumatic epilepsy. If you look at the other 50% and then question how come they don't develop post-traumatic epilepsy, what's going on? Do they have some gene that would prevent them from developing epilepsy, or the epilepsy group already has some genes that actually the genetic makeup that actually predispose them to develop post-traumatic epilepsy? So those will be interesting questions to know. So the timing, and then the animal model really show that it's a 3-day critical period that if you intervene, you might be able to change outcome. This is from animal, but not from human study. So not necessarily can translate that to human, but it will provide a food of thought to think about what could be the potential mechanism and what we can use to intervene to change the outcome. So I would like to discuss something called the Twohit hypothesis for post-traumatic epilepsy. The Twohit hypothesis been pretty popular in oncology, in cancer research. And the idea is that it requires 2 hits for cancer to develop in a person. And the first hit is really, they have some kind of genetic makeup, like people who have genetic, predisposition for breast cancer to happen, or for colon cancer to happen. That's the first hit. And the second hit is in the post-traumatic epilepsy is a head injury. So this patient could go through life, even they carry the gene, they could go through life without problem if they could really prevent a head injury or a severe enough head injury. They might never develop epilepsy. But if they got the second hit, that would set the epileptogenesis in motion, and they would have a higher chance. So they would actually go into the mode of developing post-traumatic epilepsy. So now we are adopting the same thinking for post-traumatic epilepsy, very similar to what in cancer research. And if we believe this is true, or we want to test out this hypothesis, we really have to tease out the group and look at if there's a certain genetic makeup that actually could contribute and support these ideas. And I just want to mention there might be other accessory factors, because after head injuries, if there's a significant brain injury, there's a process called neurogenesis. Some of the neurons get regenerated. Neurons in general don't regenerate, but there's still a very small number of neurons that actually will get boned. New neuron got boned, but a very small number, and the process is called neurogenesis. And it does happen after head injuries. And the repair of the brain tissues, all those things might have contributed, and depends on how a person's genetic makeup is. So that process could be a little bit different from one person to the other. And so based on the conceptual understandings that I have discussed, so it's in the timing of starting the treatment is crucial. If we have a treatment, we must give the treatment to the patient in the correct time frame. Even the treatment is effective, if you give it too late to the subject, it's not going to work. And so this will be one issue that has to be determined. And so there were a few lines of evidence from all kinds of epilepsy researches showing that there were certain genes might be implicated in the development of post-traumatic epilepsies. For example, one is this mTOR model. mTOR is a pathway that have been identified to be important for some of the seizures and in pediatric populations. And there's an antibiotic called rapamycin. Actually, if you keep the patient on this rapamycin medications, it does have quite a bit of side effect, but updated version of rapamycin can be developed if we know that rapamycin can inhibit these pathways and prevent seizure from happening. So the question is the mTOR pathway is involved in some of the patients, so they have a certain tuning of these mTOR pathways that actually, help them for a certain group of patients to develop post-traumatic epilepsy. Another thing that might be implicated is BDNF. This is a growth factors, and when I mentioned neurogenesis, the rebirth of regeneration neurons, they require using nerve growth factors, and BDNF is one of it. And then is the TRKB receptor, TRKB receptors. This all might be implicated in the epileptogenesis process, and might be the intervention point that we can think about and develop to see if we could use it to stop the process of epileptogenesis. There's another antibiotics called ceftriaxone. Actually can restore the glutamate after TBI, and they might reduce the post-traumatic epilepsies. But unfortunately, all these different needs might not be the correct one. It just has certain evidence from animal studies, and it takes years of study to really find out whether they really will pan out or not. And there were also over the years, people try to look at the genetic propensity for post-traumatic epilepsies. There were certain things that have been identified. The ApoE4, which is related to dementia too, seems that the carrier of this has a little bit higher risk of developing post-traumatic epilepsies. Interleukin-1 beta, this is an inflammatory marker. It's an immunological system, also seems to associate with it. And so this is understandable that after a head injury, there's some kind of immunological reactions in the brain that's different from before the head injuries during the recovery phase, and some of the inflammatory biomarkers might associate with the development of post-traumatic epilepsy. But exactly what role was all this different immunological marker play would take time to tease out. So let's come back to the clinical side. So basically, acute provoked seizures, those patients should be treated. The long-term seizure medication treatment is now recommended for head injury patients. But once they have a diagnosis of post-traumatic epilepsy, means spontaneous recurrent seizures, after a head injury, could be 2 years later, they should be started on treatment. I usually start them on seizure medication even after 1 seizure, if I highly suspect this is a post-traumatic epilepsy. I don't wait until the 2nd seizures. If the EEG is abnormal, I definitely will jump on the study. Even EEG is normal, even 1 seizures, within the context, if there's comparing enough that to be a post-traumatic epilepsy, I will start the treatment, because it's 2 years later, it's no longer provoked seizures. And then we definitely would have intractable cases from the group of patients with post-traumatic epilepsies. In our VA population, many of our veterans have some TBI histories in our seizure clinic. And so some of these patients, their epilepsy cannot be controlled with medical treatment alone. We have to think about surgical treatment. And the traditional surgical treatment is resection surgery, basically take out the areas of seizure focus. And the most commonly done resection surgery is a mesial temporal anterior temporal resection. So there's a small scale study with 30 subjects showing the outcome is no difference from other subjects with temporal epilepsy. The surgical outcome is no difference, means you can consider resection surgery based on this small scale study. If they are medically refractory, means medication alone is not adequate to control the epilepsy. Those patients can be evaluated for surgical resections. But in more recent years, it's not just resection surgery. There were different ways of neurostimulation methods were developed in the past 20 years also. The first one was called vagus nerve stimulator. It was approved by FDA in '97. And more recent years, one is the vagus nerve, the INS, responsive neurostimulation or different stimulations, all been FDA approved for treating seizures and epilepsy. In general, it's not a cure. The resection surgery has a higher chance of reaching seizure freedom for a cure. But neurostimulation, in general, is not a cure. However, the efficacy number seems to be quite impressive too. The efficacy means the seizure control improve, and it's 50% reductions, and the efficacy number is in general better than what we can achieve with medication alone or combined with medications. For example, and then because we have more data from the vagus nerve stimulation patients, we look at the patient who have post-traumatic epilepsy and they have vagus nerve stimulations. There's a mean reduction number based on 28 patients, 5 years, 68.4%. And then there's a large scale of registry of vagus nerve stimulation of 7,583 patients. Those with clinical response after 2 years of vagus nerve stimulation, post-traumatic epilepsy patients, 78% had response. And then non-PT patient, 61% has response. It means they improve on this treatment. It's not a seizure freedom type of improvement. They did improve, significantly improve. And in our hands, we do responsive neurostimulation at the VA for our patient and in our limited numbers of patients. Some of them really have post-traumatic epilepsy and they did improve too. And we also had some resection case. They also improve after the surgeries, resection surgeries. So all this treatment can be recommended for the intractable patients. So that's where we stand for the basic understanding, basic science understanding of the clinical treatment for post-traumatic epilepsy. And just like I mentioned at the start, this is in human history, we probably have associated the head injury to the development of post-traumatic epilepsy in ancient time. However, there was still many new understandings that need to be explored and established. And so we are running a a DOD-sponsored research study at the VA, West Los Angeles VA, to study post-traumatic epilepsy. And basically, we would like to test the Twohit hypothesis that I mentioned in the talk, and to see if we could identify some kind of genetic predisposition for the subject to develop post-traumatic epilepsies. And if the study finding is successful, that will bring upon a new approach, a new concept, and how to treat the post-traumatic epilepsy, and how to intervene, and how early to intervene, and even pre-screening patients or subjects who might have high risk of developing post-traumatic epilepsy even before the onset of epilepsy. Okay, that will conclude my talk for today. Let me know if you have any questions.